Now we'll start the next session about paraproteinemias. The first talk is from Dr. Ahmad Alhuraiji. Dr. Ahmad is a hemato-oncologist consultant working in the Department of Hematology at Kuwait Cancer Control Center. His main focus of interest is the field of leukemia, myeloproliferative neoplasms, myelodysplastic syndrome, and plasma cell disorders. He is involved in education and training of residents of Kuwaiti Hematology Residency Program and work with other colleagues to establish the Adult Hematology Clinical Fellowship Program in 2020. Personally, I do have a lot of communication with Dr. Ahmad Alhuraiji about paraproteinemias and protein electrophoresis results. And I have found, or I have been impressed by his knowledge and patient care attitude. So let's welcome Dr. Ahmad to this talk.
Assalamu alaikum. Good afternoon, everyone. And thank you, Dr. Girish, for your kind words. And I would like to extend my thanks to the organizing committee of the Lab 2024 Congress for their kind invitation. And I'm very happy here to be talking about the multiple myeloma in 2024. I know maybe the talk will be mixed between a clinical as well as a laboratory, but I was asked not to talk about the laboratory aspect because Dr. Girish and other colleagues will focus on the laboratory aspect of the multiple myeloma. Therefore, I'll just give you a glimpse of what's going on in the field of plasma cell disorder in general, and what is the and how the field is moving in terms of therapeutic options when it comes to multiple myeloma, diagnostic criteria, risk stratification, and response evaluation when it comes to the lab testing. So, multiple myeloma in Kuwait, we encounter around 40 to 50 cases a year in Kuwait. We had around 382 patients over the last decade, with a median age of 59. We tend to see a younger population of multiple myeloma when compared to the other Western countries, where the median age of multiple myeloma is around 70. So our median age is slightly lower, is around 10 years younger than, and this has been seen in other countries in the Gulf region, where Qatar also reported a median age of 57, as well as Saudi and other countries. This is the 5-year overall survival of the multiple myeloma based on the SEER data from the National Institute of Health in the United States. And as you can see also, the median age of diagnosis of multiple myeloma is around 69. The good thing about multiple myeloma that the survival of multiple myeloma has improved dramatically in the last 10 years. And this is largely driven because of the newer therapies that are introduced and approved in the field of multiple myeloma. And this is the SEER data looking at and projecting the 5-year overall survival. And when I'm talking about the drug development in the multiple myeloma, you can see here from 2023, we have from 1950s, we have only one medication called melphalan, and this is a chemotherapy. And we did not have any drug approval for almost 30, 40 years until the thalidomide was introduced in 1996. And then in 2003, we had the bortezomib, which is a proteasome inhibitor and that controls the multiple myeloma very well. And then later on, we had, over the last, if you can see that the slide gets more busier whenever you move to the right side around 2020. And then also, I forgot to add, there are 3 drugs approved in the last year, 2023, focusing on what we call it a bispecific T-cell engager, sorry. When it comes to the diagnostic workup, I just put one slide on what tests that we are usually doing. We're focusing on 4 components. The first one is the blood. We do the CBC, we do the routine chemistry, and we do the serum protein electrophoresis, urine protein electrophoresis, Bence-Jones protein, and free light chain assay. By this testing, you can identify up to 97% of the multiple myeloma cases. As you know, there are patients with multiple myeloma, what we call it a non-secretory multiple myeloma. They don't have monoclonal protein. They don't have free light chain secretions. Therefore, those patients are a minority, representing 2 to 3% of the all myeloma cases. And those patients are usually diagnosed based on the biopsy from an organ or bone marrow biopsy or any infiltration involving any organ. The bone marrow evaluation is very essential, looking at different things, looking at the morphology, cytology. We also do what we call the flow cytometry and cytogenetics. The flow cytometry, this is very important to document that there is a clonal plasma cells. As you know, we have around 5% of the bone marrow representing a plasma cells, but they are a normal functional plasma cells. But whenever there is a plasma cell disorder, there is an increase in the plasma cells, and the plasma cells are what we call the clonal of one population, and they usually dysfunctional. They don't produce a normal immunoglobulins, and they might produce a harmful proteins called the monoclonal PANs. We also do imaging, which is part of the evaluation. That involves the low-dose whole-body CT scan, and sometimes we end up doing nuclear imaging such as PET-CT or whole-body MRI. So the role of imaging in multiple myeloma, we have 3 imaging modalities in multiple myeloma. The standard of care that you do a whole-body low-dose CT scan and able to detect any lytic lesions anywhere in the body that can represent what we call it a myeloma-defining event. You know, we have 3 components of plasma cell disorder: the monoclonal gammopathy of undetermined significance, we have the smoldering myeloma, and we have the symptomatic myeloma. And there are some few definitions that upgraded the smoldering myeloma into a symptomatic myeloma, even if they don't have anemia, if they don't have renal failure, they don't have hypercalcemia, and they don't have lytic lesions. And we'll touch base on this. Now, PET-CT, we usually do it in patients with extramedullary plasmacytoma or patients who have an extramedullary involvement of their disease. The PET scan does not play an important role in the diagnosis, but also plays an important role in the prognosis, because those patients who had treatment for their multiple myeloma and they achieved a PET negativity down the line, they usually have a very good outcomes. The MRI is done in specific cases, specifically in patients with a smoldering multiple myeloma, where you have like a high plasma cells in the bone marrow, 10 to 60%, and you don't have any evidence of end organ damage. The end organ damage is not there, then you think about what we call the smoldering myeloma. The MRI here plays an important role based on the German experience, where they showed that if you have a more than one lesion of 5 millimeter or more, then this patient will have a very high risk of progression to a symptomatic myeloma in a very short period of time. And we should upgrade this smoldering myeloma, the asymptomatic myeloma, to a symptomatic myeloma, and treatment should be started as soon as possible. So in the past, we used to do what we call the skeletal survey, which is an X-ray looking at different bones in the body to detect any lytic lesions. However, this has not been recommended by any guidelines nowadays, because the sensitivity rate of the skeletal survey is around 20%. So you may miss 80 to 90% of the cases if you do a skeletal survey. Therefore, it's not recommended unless you don't have access to CT, you don't have access to PET, you don't have access to MRI, then it is justified to go ahead and do a skeletal survey. Now, when it comes to the risk stratification, we depend on blood tests, and usually they are the albumin level, the beta-2 microglobulin level. I remember, I'm not sure if Dr. Ahmed Sarraf is here or not, in our center, the beta-2 microglobulin was reported to be above 4.6. But this is not helpful to us as a hematologist practicing, looking after the patients, because 4.6 doesn't mean the patient, is he a risk stage 2 or 3? We have to have a more accurate testing, and they do, I think, dilution of the testing until they tell us, okay, the P2M is not more than 4.6, but it's like 5, 10, 15, etc. So the international scoring system based on the albumin and beta-2, and also the revised ISH, what we call it, added the lactate dehydrogenase, the LDH level, also to be an important risk factor, and some cytogenetic abnormalities that plays an integral part of the risk stratification and treatment management and the treatment selection, I mean, when it comes to the newly diagnosed multiple myeloma. Now, in the past, we tend to say, okay, a patient had multiple myeloma, and then he has been treated for what we call it the multiple myeloma, and the response evaluation is that we need the monoclonal pant to disappear, we need the free light chain to normalize, and we need the bone marrow plasma cells to be in remission where we have less than 5% plasma cells. But this is not the case anymore. Now we have to have a more detailed, sophisticated testing in order to detect a very minority involvement by the plasma cells based on what we call it minimal residual disease. And this has been done by different methods. Number one is the flow cytometry, looking at the depth of the remission in 1 in 10,000 cells or 10 in 100,000 cells, or next generation sequencing where you sequence the IGH locus and then you try to follow it up down the line. And we have what we call it now a mass spectrometry, which is very important testing method that has been validated by many myeloma experts and working groups to be as good as the bone marrow evaluation, as good as the PET evaluation, or even better than the flow cytometry or cytogenetics. And I encourage all the biochemistry labs here in Kuwait, specifically at Kuwait Cancer Center, to have the mass spectrometry, because this is a non-invasive test. You don't need to do a bone marrow. You don't need to do like a sophisticated imaging. You just need to draw blood and then send it for MRD based on the mass spect. And this has been a very powerful prognostic marker across all clinical trials when it comes to multiple myeloma. So here, patients who had an MRD negativity based on the flow cytometry or NGS, they have an excellent outcomes down the line at 4, 5, 6 years. None of the patient had relapse or progressed down the line. So it should be a surrogate marker for an endpoint for any protocol that we are using nowadays. PET negativity also plays an important role. We now do it at baseline, and then we do it at the follow-up. So those patients who achieve a PET negativity usually have an excellent outcome when it comes to multiple myeloma. How do we treat multiple myeloma? The multiple myeloma is treated based on the first question, is the patient transplant eligible or not? Because the transplant is an important part of treatment. So, and the transplant is decided based on the age of the patients, comorbidities, and performance status. In general, patients above the age of 65, we usually say these are not transplant eligible. Those with multiple comorbidities or they have a poor functional capacity, then we exclude them from transplant, and then this will dictate the, down the line what anti-myeloma treatment you will be using. So here in Kuwait, the treatment program usually starts with an induction protocol, either with a triplet combination or quadruplet combination, and then followed by transplant, autologous stem cell transplant. And then this has to be followed by what we call the consolidation and then maintenance on an oral treatment. If the patient was deemed to be unfit for transplant. Then we have to choose the other pathway, which is going for induction and then maintenance without transplantation. Now, the question always comes to play is, do we need to use a single agent for treatment, or a doublet, or a triplet, or quadruplet? In general, the more, the better, but the more toxicity you will get. So, however, in patients who are young, fit, and you're planning to have the best outcome down the line, because in general, the multiple myeloma overall survival was around 1 to 2 years in the past, and now it's more than 10 years. So patients are living longer, and as I said, the median age here in Kuwait is 59, so they are younger population, so we have to control the myeloma as much as we can. Therefore, a quadruplet combination is the now standard of care in Kuwait, where we use a monoclonal antibody called daratumab, which is a CD38 monoclonal antibody, along with other medication such as proteasome inhibitor, immunomodulator, and dexamethasone. The triplet combination, this was done in 2000, 2010, 2015. We were using a triplet combination where we were using the VRD protocol, which is a triplet combination, and this has led to a significant improvement in survival. So the transplant question always comes into the play. Do we need to transplant patients? Yes, the transplant gives you a deeper responses and control disease for a longer period of time based on the French as well as the US trial, the termination trial, where the transplant was found to be beneficial. Now, this is what we have in the real-world outcomes with the what we call RVD induction that has been used for the last couple of years, and we have changed recently that we added another component to the RVD protocol. CTD, this is another protocol called the MRC myeloma from the UK, where they use an oral regimen with the thalidomide, dexamethasone, and cyclophosphamide, and followed by transplant. They have like a median progression-free survival, so they were able to control the disease for almost 2.5 years. I'll skip that. This one. I think I have other slide. I'm not sure whether, because I'm missing a few slides here. Do we have other, Doctora? I think I have other slides were sent recently.
Doctor,
Anyway,
we don't have here access to the slides. I think maybe the IT people can help us.
I'm not sure the IT people is here because
can you help us? Because the doctor is missing some slides.
Anyway, I'll move on because for the sake of time. Now, as I said, triplet combination was the standard of care until 2022 in Kuwait. And then based on the Cassiopeia study, the monoclonal antibody, the immunotherapy, was introduced in combination with the triplet combination. So that resulted in a very high response rates and the very high complete remission rate among all patient subgroups. And as you can see here, the progression-free survival was, you can see the curve is flat. No one is progressing on this protocol. However, on the other comparator arm, which is the VTD, you can see that the patients are still progressing and the curve is going down. Here, the median overall survival. As you can see here, at 5 years, you can see here the median overall survival is more than 85%. I think we'll skip that. Yeah, the Griffin trial, okay. The Griffin trial have used the backbone that we're using, which is the RVD protocol, and they added daratumumab. The daratumumab is a monoclonal, again, antibody against CD38. And as you can see here, that two things, the response rate was higher, and the MRD negativity rate, the minimal residual disease. So we were able to achieve a very deep remission with the daratumumab and RVD protocol. 51% of the patients had achieved MRD negativity with this combination. So again, at 4 years, 87% of the patients had no progression of the multiple myeloma. Again, the MRD negativity rate continues to increase over time. I think we'll skip the adverse events, and this is the subgroup. Here's sometimes what we do in our analysis to see which group of patients they would benefit more and which group of patients they wouldn't benefit from this intervention. Again, here, the patients with 2 or more high-risk cytogenetics, the 17p deletion, p53 mutation, or chromosome 1 abnormalities, they usually, if they have 2 het and 2 genetic lesions, then the outcomes wouldn't be optimal, even when you introduce the daratumab and to the backbone of the treatment. Okay, I'm sure that these are not the updated slides because I've done the 2024. Anyway, we'll.
Okay, our colleagues will check it.
No, I think we have only 10 minutes because of the program, so I don't think that it is reasonable to change. Anyway, so the NCCN guidelines, which is the National Comprehensive Cancer Network in the United States, they usually put an updated guidelines for all the hematologists across the globe. And as you can see here, the daratumab was put as recommended regimen along with the lenalidomide, bortezomib, and dexa. Therefore, a 4-drug regimen is beneficial in multiple myeloma. And the Mayo Clinic group was one of the largest group looking after myeloma in the United States. Also, the risk stratified patients across the cytogenetics, where if you have what we call 17p or chromosome 1 or 14 chromosome abnormalities, then those patients, they would benefit from the addition of monoclonal antibodies. I think this is like a duplicate of the HD. Yes, here, this is one of the, I think, in general, multiple myeloma, we tend to use the daratumab or the treatment indefinite, but here, this master trial looked at a fixed duration therapy. And they did the minimal residual disease. Once you achieve an MRD negativity, that you don't detect any myeloma cells based on the bone marrow evaluation and PET scan, you may just wait another 12 months and then you can stop treatment. And this has been a very practical and well-loved by many groups to stop treatment at a time point where you don't need to continue for ever the treatment. Therefore, I think that will call for help from the biochemistry departments to get the mass spectrometry to do the MRD based on the mass spec to patients with multiple myeloma. I think this is also the Master and Griffin trial. The addition of monoclonal antibodies has improved the outcome. In the transplant ineligible, patients who are frail with comorbidities, who cannot tolerate the transplant, then we usually go with a very little gentle protocols such as the VRD Lite, where we reduce the doses of many medications and we give it over a longer period of time. Until the Maya protocol came, where we give the monoclonal antibody with a pill and dexamethasone, and the outcome was impressive here. As you can see here, at 5 years, the median progression-free survival was not reached, meaning that patients at 5 years, they're still more than 50% of those, they don't have progression of their disease, as well as the overall survival at 5 years is around 66%. And you can see also the MRD negativity, where it's now it's a surrogate marker for survival is higher. this is the based on the age and frailty. Okay. The European Myeloma Network also studied what we call it a DARA VMP. They give Velcade in addition to the daratumab in patients who are elderly. And this has also, I want to go directly to the curves. You can see here an elderly population where they don't tolerate the treatment very well. They were able to control the disease for a longer period of time. And the overall survival was 75% at almost 4 years. And the DARA-RD, based on the Maya protocol, is now being the standard of care in many countries, including Kuwait. I think this is the primary therapy for non-transplant eligible, which are the DARA-RD and VRD Lite, and this has been adopted and used in Kuwait. Anyway, the immunotherapy has evolved dramatically over the last 5 years. We have what we call it now the antibody-drug conjugate. We have something called the bispecific T-cell engager, and we have the CAR T-cell therapy. The antibody-drug conjugate comes from an idea that you have an antibody which linked to a toxin or a chemotherapy, and the patients will receive this monoclonal antibody, and whenever it's linked to the receptor, it will get internalized inside the cell, and the toxin will be released inside the cell to intercalate with the DNA and cause cell arrest. This is number one. Number two is the bispecific T-cell engager. You have an antibody that has two heads. One is linked to the T-cell, and the other one is linked to the myeloma cell. And we usually target what we call it a BCMA antigen on the myeloma cell, and the BCMA is called the B-cell maturation antigen. The bispecific T-cell engager has been approved across many hematological malignancies, leukemias, lymphomas, and now myeloma. We have 3 drug approval. These will bring the T-cells into proximity with the myeloma cell, and it causes T-cell activation, proliferation, and enhance the tumor killing. The number 3 immunotherapy that has been also showed an impressive, in the relapse refractory setting of multiple myeloma, we hardly have like 40–50% response rate. But when you use the CAR T-cell therapy, the overall response rate hit the 100% mark. So you get 100% overall response rate with the CAR T-cell therapy. The idea of the CAR T, that you get the T-cells from the patient himself, you transduct this with a vector to make these T-cells educated to attack the tumor cell. And whenever you do this in the lab, and the lab processing takes almost 3 to 4 weeks in general, and whenever you do this, you then enhance the T-cell for proliferation, and then you admit the patient and you give him the T-cells that he had before, after education, I would call it. And this has resulted in impressive responses in the field of multiple myeloma. And this has moved, I would say, in the first or second line of treatment of multiple myeloma with the CAR T-cell therapy. The key messages that I would like to give you here, from a biochemistry lab, if you see any patients with hypercalcemia, patients with high total protein, patients with low albumin, please think of multiple myeloma, and please call the hematologist or whoever is in call to look after the myeloma. We have a delayed diagnosis in multiple myeloma, and patients usually present with an extensive disease. I remember I had a patient who had a total protein of 125, which is extremely high, and the patient was overlooked by many physicians, even the internist, nephrologist, as well as the neurosurgeon. So he had a spine surgeon, and the biopsy from the surgeons, when he had a decompression fixation, it did show a plasma cell disorder after the spine fixation. So when we looked back at the biochemistry, his total protein was very high. He had anemia, and he had hypercalcemia. So please, whenever you see a high total protein, think of multiple myeloma. Try to send for serum protein electrophoresis. Dr. Girish is very helpful, open 24/7. he can help at any time. With that, I conclude, and thank you so much for listening.
Thank you, Dr. Ahmad. Reminder that you can scan the barcode on the podium to ask questions. Now let's welcome our next speaker, Dr. Devaki Nair. She's professor in CVD Prevention and Health Inequality, University College London, Royal Free London, and Health Service Laboratories. She's she's qualified from Madras Medical College, India, and completed her postgraduate studies at the Royal Free Hospital, London. Her special interests include familial hyperlipidemia or hyperlipidemia of genetic origin. As an academic with University College London, her research interest includes lipids, CVD prevention, and renal disease. She's the specialty lead for the Health Service Laboratory that serves 4 major hospitals in Northwest London. Welcome, Doctor.
Do another lecture. So this is a very biochemical involvement for managing multiple myeloma. We do so many protein electrophoresis. I'm sure every lab does lots and lots of protein electrophoresis, either requested by the physicians, or when we find that the protein levels are high, we sometimes reflex protein electrophoresis as part of that. So the main interest of detecting monoclonal immunoglobulins when multiple myeloma is suspected, early detection of an asymptomatic myeloma, and to monitor the evolution of the disease. Other interests would be in protein electrophoresis is detection of non-gammopathy related pathologies, which I will briefly discuss at the end. So if you look at the protein electrophoresis profile, each fraction contains several proteins of similar charge. I haven't gone into the technology because there is another lecture on capillary electrophoresis, capillaries, after this. So albumin, the highest peak, the albumin, the alpha-1 region, you have 1-alpha, alpha-1 antitrypsin, alpha-1 acid glycoprotein or orosomucoid. Alpha-2 has the alpha-2 macroglobulin and the haptoglobin. And you can see the third, the beta-1 is the transferrin or hemopexin. And beta-2 contains the C3 and the C4 complement and the IgA, and the gamma, which is the last peak, which has the IgG, IgM, IgA, DE, and also CRP moves in the same peak. So that's how a normal peak, normal electrophoresis looks like. So the basis of this is, the plasma cells and the immunoglobulins, the different types of immunoglobulins, which all of you are familiar with, IgG, IgA, which is a dimer, IgM, which is a pentamer, IgD, and IgE, and you can have monoclonal proteins from any of those. In the normal context, so every plasma site elaborates the immunoglobulins, and because there are several clones, it's always polyclonal immunoglobulins, and it's not monoclonal. And if you look at the pathological context, it's there's one clone, and that, because it's of the same type, the same type of protein, it forms a monoclonal peak, as you can see, which is marked as a red arrow. So this is in contrast to the usual normal polyclonal increase. And if you look at etiology of the newly diagnosed monoclonal immunoglobulins, MGUS contributes to 51%, and smoldering myeloma around 6%, and multiple myeloma around 18%. So 75% are myeloma-related abnormalities when you see a monoclonal immunoglobulin. And around 11% AL amyloidosis, and recently, in the last few years, AL amyloidosis has become more and more important to be diagnosed. In the early days when I started, we didn't know much about AL amyloidosis. We are a national center for amyloidosis, and we do more protein electrophoresis and related investigation for our amyloid unit, much more than what we do for multiple myeloma. Macroglobulinemia, around 3%. Plasmacytoma, solitary cytoma 1%, and lymphoproliferative disorders can also present with monoclonal proteins around 4%. So MGUS is monoclonal gammopathy of unknown significance, which means that they do have a monoclonal protein and the progression is not as multiple myeloma, and the clinical features are not like the multiple, they don't have the multiple myeloma related symptoms or signs. Smoldering myeloma, they're slowly turning into multiple myeloma and real diagnosis of multiple myeloma. So the MGUS and the smoldering myeloma, the asymptomatic precursor of multiple myeloma. So MGUS definition: monoclonal gammopathy of undetermined significance, that's what it means, and without any clinical or radiological abnormalities. So they don't have any bone abnormalities, they don't have any clinical abnormalities like anemia, reduction in platelets, so on. So they are asymptomatic. Clinical characteristics would be monoclonal protein concentration is less than 30 grams per liter, which is possible for us to demonstrate because we can measure by densitometry the peak, and then we can say whether the protein concentration is high or low. Clonal bone marrow plasma cells, which the hematologists do, it's less than 10%. They don't have hypercalcemia or high creatinine. They have a normal blood smear. In serum, normal concentration of the polyclonal immunoglobulin, which means that immunosuppression is not seen. If they have monoclonal proteins malignancy, then the immunoglobulins are suppressed. Here, the immunoglobulin levels, other than the monoclonal protein, they are normal, so polyclonal. Urine, they don't have Bence-Jones protein or present at a very low concentration, and the concentration is stable for a very long time. So they're being monitored, and we cannot ignore them, and they need regular protein electrophoresis. Multiple myeloma, we had a whole lecture, so I won't be going into too much of detail, but nevertheless, second most frequent bone marrow malignant tumor after leukemia, 1% of total cancers, 60,000 new cases in Europe, 250,000 new cases worldwide, and 15,000 deaths due to multiple myeloma still, in spite of all the successful treatments. So multiple myeloma affects the bone marrow due to the plasmacytes overproliferation, and the symptoms, they bleed, they come up with bone and back pain, recurrent infections, immunosuppression due to immunosuppression, symptoms of anemia, tiredness, respiratory problems, and frequent fractures. These are the clinical signs. So how do you differentiate MGUS, smoldering myeloma, or multiple myeloma? So MGUS, as I said, the concentration of the monoclonal protein is less than 30 grams. Smoldering myeloma, it may be around 30 grams. And multiple myeloma, it can be high, it can be slightly low, but still may have clinical signs and symptoms of multiple myeloma, and the bone marrow may show plasma cells. The bone marrow plasma cells are always high with multiple myeloma and smoldering myeloma, but it's less than 10% with bone marrow plasma cells. Myeloma defining events, which the short form is CRAB, the calcium elevation, renal insufficiency, anemia, and bone disease are absent in MGUS and smoldering myeloma, but it's present in multiple myeloma. 60% BM plasma cells, serum free light chain ratio may help you, and one focal lesion detected by MRI. So these are the criteria for diagnosis. So international guidelines for serum-free light chain analysis in multiple myeloma and related screening is recommended in combination with electrophoresis. It has replaced Bence-Jones protein, and it can replace the 24-hour 24-hour urine Bence-Jones protein, as well as the immunofixation, which we do with the urine if we can get the free light chains. For AL screening, that is amyloidosis screening, 24-hour urine and IFE is still recommended, and it's unlike the multiple myeloma. So if you suspect AL amyloidosis, you still need to do the urine as per the international guidelines. They are relatively small proteins. The molecular weight of monomeric kappa is 25 kDa and dimeric kappa lambda is 50 kDa. The light chain can relatively easily pass through the glomerulus and into the proximal tubule where they are absorbed. And if you look at a healthy individual, half a gram of light chain that is produced per day is completely absorbed. And so in a normal individual, you're not going to see any light chains. But the kidney has the capacity to reabsorb up to 10 to 30 grams of protein per day. Very light levels of light chain enters the urine. In a patient producing low quantities of FLC, the renal reabsorption capacity it will not be overwhelmed. But in renal failure, this may be slightly different, and you may get higher FLC. So serum FLC is prognostic for MGUS progression. If you're monitoring MGUS and if you're measuring serum FLC and goes up, then it indicates there is progression. Prognostic for myeloma outcomes, smoldering myeloma, progression, plasmacytoma, progression of amyloid, AL amyloidosis, and Waldenstrom's outcome. So it does help in the outcome for these diagnosis. Normal FLC ratio is 0.26 to 1.65, and abnormal ratio is less than 0.26 or greater than 1.65. So how does a normal profile look like? I showed you the earlier one. No additional peak or distortion in beta 1 and beta 2. Fractions are within the reference range. Beta 1 is usually larger than the beta 2. So when you look at the electrophoretic strip, that's how it looks. So monoclonal immunoglobulin, you can see the red arrow, that is a monoclonal protein, a peak in the gamma region, no Gaussian aspect, and this needs to be investigated by immunotyping or immunofixation to prove that it is which type of immunoglobulin that is. Monoclonal versus polyclonal, you can see the rounded top polyclonal increase as against the pointed peak for the monoclonal band. And it's usually very distinguished from the polyclonal increase. And you can see that sometimes you can have a weak distortion in the gamma. And again, when you see a weak distortion, don't ignore, you go and do an immunofixation, which might help us to see whether there is, especially IgA concentration is low, IgD concentration. If you have multiple myeloma involving these, the concentration may not be as high as the immunoglobulin G, and therefore you may miss a diagnosis. And if you see any distortion, you need immunofixation. In the beta, it's slightly difficult when it becomes in the beta 2 region. As you can see, the peak in the beta 2 is increased, beta 1 is less than the beta 2. Usually beta 1 is greater than the beta 2, and it's, when you see such distortion, you have to do a immunofixation to prove that it's not multiple myeloma. Beta 1 region also, you can have additional peak. It usually comes as an additional peak rather than the peak height. And again, immunofixation should be done to prove that it is not myeloma. In alpha 2, it's not unusual to see distortion in the alpha peak, and again, to be investigated by immunofixation. If you see a monoclonal immunoglobulin in alpha 2, it's important that you confirm that it's monoclonal immunoglobulin, and it's not a hemolyzed sample, and it's not haptoglobin hemoglobin complex. As I showed you, there these proteins, several of the normal proteins move in these regions, and you need to rule out it's not, especially if it's in the alpha 2, that it's not a haptoglobin hemoglobin complex. And there's another condition where you have have the haptoglobin phenotype genetic mutation who is heterozygous for that will, and again, that is not going to cause an increase in the alpha-2 portions, and you shouldn't ignore that saying it's a abnormal genetic type. And if you see a peak, you need to do immunofixation. So what are the rules for identification of monoclonal protein? Presence of a peak or distortion in gamma, presence of an additional peak or distortion in beta-1 and beta-2, beta-2 bigger than beta-1, out of inflammatory context or hepatic disease. In these diseases, it can be, the beta-2 can be high. Increase of beta-1 out of iron deficiency anemia or hemolyzed sample, and isolated increase in alpha-2 out of inflammatory context. So rule out inflammation in many of these conditions because of the effect of the acute phase proteins. And if you see distortions, 2 peaks, again, immunofixation is required, and you cannot ignore, even if they are small, you need to do the immunofixation. Sometimes they get polymerized. The monoclonal proteins get polymerized, monomeric form get polymerized, and you may see that as a distorted peak, or you may think it's a polyclonal one. So it's important to rule out that. And you'll be listening to the Capillary soon. So there are tools helping the interpretation, peak quantification, say use of the control curve as a reference curve. You can zoom it, you can smooth it, and curve display, which helps you to pick up these abnormal monoclonal proteins. The peak quantitation will be required for MGUS, the smoldering myeloma, and multiple myeloma. As I said, whether it's less than 30 grams or more than 30 grams determines with or without myeloma signifying clinical features. Again, with successful treatment, now oncologists or hematologists also use it to assess the response to treatment. And if the serum and urine M protein component detectable by immunofixation but not by electrophoresis, there's a chance that more than 90% greater reduction in the M protein plus M component, that is less than 100 milligrams per 24 hours. So greater than 50% reduction of serum M protein is partial response to the drug, and it's important because they have so many drugs and they can change and use even antibody treatment. It's important that we measure and we are able to show that if there is a reduction, so partial response. Progressive disease increased 25% from the lowest response value in one of the serum M protein, and it's important that we report the amount of M protein for assessing the response. And as I said, the reference curve can be used to, it will overlap and it will be easier to pick up these. And these days, in my days, it was agarose gel where I had to sit and look at all look at the strip and report visually. Then we had the CBA agarose gel electrophoresis, which is slightly automated, better visually. Now we have capillaries, which the interpretation is quite easy, and the machine does it all. And you have the purple profile, and you just overlap, and you see, and you find out. Sometimes there is a slow migration of a peak. A monoclonal component is suspected when the single protein is delayed. So where you expect the peak, where you expect that to come, it doesn't. And then to confirm the presence of the monoclonal component in such a sample, you will treat it with beta-mercaptoethanol and repeat the serum protein electrophoresis. And how do you prepare? You prepare 1% BME reducing solution, mix it with 90 microliters of distilled water and distilled water or fluidal or physiological water, and then mix 100 microliters of the reducing solution to 300 microliters of the serum, incubate for 10 minutes and immediately subject to serum electrophoresis. And if you have the peak still, then it means that it is a monoclonal protein. The other non-gammopathy-related diseases are inflammation, nephrotic syndrome, cirrhotic profile, hypogammaglobulinemia, hypergammaglobulinemia are important, but not in relation to not in relation to multiple myeloma. But when you see an electrophoresis, these are the other diagnoses which you need to be aware of. In acute inflammation, you will see the alpha-1, alpha-2 increased, and it is important that you rule out if there is a monoclonal protein in that. In acute inflammation, there is increase alpha-1, alpha-2, decrease in albumin. Proteins involved in the acute phase proteins are that is in acute inflammation. If it's in the intermediate stage, there's alpha-1 and alpha-2, and beta-2 is also increased, and you'll see a decreased albumin. In chronic inflammation, it's again alpha-1, alpha-2, and beta-2 and gamma, and decreased albumin. Proteins involved in acute phase protein, C3 protein, and polyclonal increase in IgA and IgG, respectively, in the beta and gamma. So these things can confuse someone looking at the electrophoresis if you have a background chronic inflammation or acute inflammation. And it's important to look at the clinical details when you report the protein electrophoresis, and if necessary, to do the immunofixation on those samples. Cirrhotic profile, very common. They may be immunosuppressed, and they may ask for a serum protein electrophoresis, and you'll see that the beta-2 gamma bridge due to the polyclonal increase in IgA and beta, which is specifically seen in cirrhotic patients, and the interpretation should do that. Interpretation should look into that and be reporting that as well. So there are some interferences, especially radio-opaque interference substances, which interfere with many of these fractions, and I've given you some of the names of the radio-opaque substances which interfere, and gives a picture that they may have a monoclonal protein, and it's important that we know if they have undergone radiological investigations, and they have used a radio-opaque material, radio-opaque material for these patients. A good electrophoresis standard should be possible to see the faint transerythrotin pre-albumin band in the serum of all healthy people. Should be possible to detect if present the heterozygosity of the alpha-1 antitrypsin, and should be possible to recognize two main components of the alpha-2 zone, haptoglobin and the alpha-2 macroglobulin, and the two main components of the beta zone, transferrin and C3, should be clearly resolved as two distinct bands, and the G zone, the gamma zone, should be possible to recognize the presence of small monoclonal protein as little as less than 1 gram per liter, and possibly the oligoclonal pattern as well should be visible. So a good electrophoresis should be able to differentiate all that. And don't forget about the cryoglobulins. The cryoglobulins is again part of the investigations for protein electrophoresis, and often the collection of sample is not right, and you can see the cryoprecipitate, and we now use a thermoflask, and the accreditation process required us to maintain the temperature and show that each sample that we collect, we have a record of the temperature. So we have a sensor, temperature sensor, in each of the thermoflasks, which we give it to the clinician, so that when we get the thermoflask back, we have a record of the temperature which we have, so that we can surely say that the cryoprecipitate is present or not. Otherwise, the cryoprecipitate precipitates in the cold weather, especially in the cold weather, and we may miss the presence of a cryoprecipitate in that patients. And you can see this is thermos with sand where it's maintained, and if you use the thermos with water, it deteriorates. And if you use a styrofoam cup, which usually the doctors pick up a drinking cup and put some water or put some sand and bring it, and it doesn't keep, and we know that it doesn't keep. And now we supply thermos flask. Whenever they request a cryoglobulin, they're asked to come to the lab, get the thermos flask, and we have a temperature sensor in that, so that we assure that when we get the sample, it's at 37 degrees till it reaches the lab, and until we put it into a water bath at 37 degrees. And then we separate two samples. One remains in the water bath at 37, one we put it in the fridge, and then we look at the cryoprecipitate and then subject it to electrophoresis. So it's important not to forget about the cryoglobulins, which is also part of the investigations, as investigation of serum protein electrophoresis. I think I'm going to stop there. Thank you.
Our next speaker is for capillary electrophoresis, Mr. Aymen Salhi. Mr. Aymen is a senior clinical application specialist with extensive expertise in analytical instrumentations and biomedical systems. With a background in experimental sciences and substantial experience in training and customer relations within healthcare and diagnostic sector, Mr. Aymen possesses many certifications in various medical technologies, marketing strategies, and training processes. He has held key roles at Pasteur Institute and many companies, demonstrating a strong track record in customer portfolio development, quality management, and market representation. He possesses a deep understanding of biomedical and clinical laboratory equipment and technology. Particularly, his expertise for capillary electrophoresis for proteins is very good. And since we are evaluating our capillary electrophoresis system at Ibn Sina Hospital Laboratory, he has been very useful for this purpose. So let's welcome Mr. Aymen.
Good afternoon, everybody. My name is Aymen Salhi. I'm product and application specialist for Serbia, Middle East, and Africa. Thank you for your presence. Thank you for this great opportunity. I'm here today to share with you the last updates regarding the A1C testing and to present to you the A1C testing using the Serbia capillary electrophoresis. So the main objective today will be to agree on the last updates and the last recommendations, talking about the last guidelines worldwide. Let's start from the basics. What is the A1C? The A1C, it's an hemoglobin and is currently defined as an hemoglobin A, 2 alpha chains and 2 beta chains. This molecule is irreversibly bound to the glucose, and we will see the irreversibly bound to the glucose, what exactly means. In a specific place, this specific place is the N-terminal line of the beta globin chain. All the other positions and all the other point of fixation are not accurate and are not irrelevant. So the only and the unique definition of the A1C was established by the master. Now for the A1C, for this parameter, we have a master. We have the IFCC, the International Federation of Clinical Chemistry and Laboratory Medicine. They have and they established a strict definition of this parameter. This parameter is defined as the stable adduct of glucose on the N-terminal amino group valine mean of the beta chains of the hemoglobin A. So the measurement of this parameter, what do we need exactly to measure correctly and to have an accurate measurement of the A1C? The first thing is to separate the hemoglobin A and measure it. Separation of the hemoglobin A and the measurement of this hemoglobin. The second thing is to separate and measure the A1C, the chemically modified fraction of the hemoglobin A by the glucose. The second thing is to detect, separate, and exclude the other forms of hemoglobins, mainly the hemoglobin A2 and the F. The fourth rule is to detect, separate, and exclude from the calculation the other forms of hemoglobins, mainly the variants, the hemoglobin parts, the hemoglobin H. At the end, the formula of the calculation of this hemoglobin will be the percentage of the glycated or the chemically modified fraction by the glucose ratio with the total hemoglobin. So for that, the A1C is considered by the IFCC again, because it was a huge journey for the IFCC. Now again, we have a master with a strict definition of this parameter, and this master was clear. He defined this parameter, as I said, as the unique biomarker for the diabetes, because we are not talking only about the measurement. We have the detection, we have the follow-up, and for this, the IFCC chooses this parameter as the unique biomarker of the diabetes. It reflects the glycemia of the previous 3 months, means 120 days, which is also very important to know that we need to have and to establish the rules and to have an accurate follow-up to have this 120 days. And it's not the case in a lot of disease, hemoglobinopathies like the thalassemia. This is why it's also very important to detect the general environment of the measurement of this parameter. It provides with the information of the long-term glycemic control and the hemoglobins existing in the normal blood. As you know, the normal case, we have 3 hemoglobins. We have the hemoglobin A, the major fraction. We have the hemoglobin A2, and also we consider that less than 0.5% of hemoglobin F existing even in the adult samples is also a normal fraction. So what are we looking for exactly? We are looking for a specific fraction of, let's start glycated hemoglobin, because it's very different, and we will see why it's very different. This fraction is included in the hemoglobin A. So as we said, that is an hemoglobin A, 2 alpha chains, 2 beta chains, chemically modified by the glucose again. So the hemoglobin A contains the major fraction, which is the native fraction, the hemoglobin A0, and the glycated forms. But the glycated forms are not only the A1C. There is a huge difference between the A1C and the glycated form. And the only and the unique significant, clinically significant fraction is the A1C. So between the glycated form and the A1C, again, there is a huge difference. And the only clinically significant fraction is the A1C. This is why we need to extract and exclude and measure only this fraction. We have almost 1% of additional fraction between the chemically modified hemoglobin A by the fructose, by the pyruvate, which is the A1A, and the A1C, the A1B, sorry. This is an illustration for a normal patient, and let's understand what we are looking for, what we need to measure exactly. In the normal patient, the major fraction in the total hemoglobins the major fraction is the hemoglobin A. The hemoglobin A, with the hemoglobin A, we have the chemically modified fraction of all the hemoglobins, called the glycated hemoglobins, because the hemoglobin A2, the F, can be also chemically modified with the glucose, the pyruvate, etc., etc. So we will have the total glycated hemoglobin. In this total glycated hemoglobin, a part of this total glycated hemoglobin, we will see the glycated hemoglobin A. A part of this hemoglobin is a glycated hemoglobin A. And we are looking for and only this fraction, the A1C. All the other forms are irrelevant. We need to exclude them from the calculation to have the real A1C and the unique clinically significant fraction. A more complex case, why it is very important to know all the hemoglobins existent in the sample. Because in a case, for example, of the presence of an heterozygous form, an S, it's also available for the C, for the E, all the other variants, you will have another context, which is more complex. We'll have two major fractions. We will have the variant, the beta variant, which is the S in this case, and we will have the hemoglobin A. The glycated, the totally glycated hemoglobin will contain all the glycated, the chemically modified forms from the S, because the S, we have also the S1C, the A1C, the A2 also related to the hemoglobin. We'll have two major forms also on this, the chemically modified, the glycated hemoglobin S and the glycated hemoglobin A. And we need to extract from all this complex only the hemoglobin A1C to have again a clinically significant parameter or a clinically significant value. Don't forget that the S1C is also existent. A more complex case which exists, the sickle cell disease. Sickle cell disease, as you know, it's an S or a CC, mainly SS, means we don't have an hemoglobin A in this case. We have a major fraction, which is a fraction, a mutated fraction. It's not the hemoglobin A. But the glycation, the reaction of the glycation in general, will continue. We will have a total glycated hemoglobin. In this total glycated hemoglobin, you will have the glycated fraction of the hemoglobin S. And in this part, you will find the chemically modified fraction of the S of the variant by the glucose. Where is the A1C in this case? In this case, there is no A1C, and it's very important to highlight it. Because with the blind techniques in general, the non-separative techniques, the techniques non-mentioning and non-detecting that we don't have the A1C, you will have a value. You will have mainly the biochemistry, the enzymatic techniques, you will have a value. And this value, it's also a glycated form, but it's not the A1C. They are reporting the S1C, which is clinically non-significant. What means clinically significant? The only fraction that we know, the speed of the glycation, the clinical impact, and the standardized one is the A1C. All the other four, we cannot use them for the diagnosis, for the follow-up, or for the decisional threshold regarding this pathology. The capillary electrophoresis principle, it's an easy principle. It's unique for Sebia. It's the Sebia technology or the Sebia philosophy based on the migration of the proteins in general using capillaries. The capillaries are installed, many capillaries are installed on the systems, and basically using the electroendosmotic flow to separate all the protein. The only, and again, the unique criteria will be the charge. There is no structure. The only criteria to differentiate and to separate the hemoglobin is the charge. As you can see, after the migration, all of this reaction will be in real time. At the end of this migration, we will have an LED system to detect all the fractions and to quantify them to give us this kind of profiles. The capillaries electrophoresis, again, what we are measuring, what we measure exactly. Is the capillary electrophoresis accurate? What is the grade of performance of this technology? Because we know everything now. Everything is defined, everything is strictly defined. Let's see what we are measuring exactly. Sepia, capillaries electrophoresis, and the system, the phoresis, we are detecting this small part, VA1C. Why we are detecting, where we are able to detect and to quantify the real A1C? Because we are able to separate, Sepia is able to separate, and the capillaries electrophoresis is able to separate all the fractions and exclude all of them from the calculation. The separation is a very important step, but the calculation also is very important because the IFCC in the program or the process of the standardization defined actually all the parameters from the beginning, from the scratch. And they defined and they give the strict formula to calculate the A1C. So the electrophoresis of Sepia follow exactly the IFCC recommendation. So if the hemoglobin is present, we need to exclude it from the calculation. The A2 is separated and excluded. And I will add something here. We need to quantify it correctly, because we need also to understand if we are in a thalassemic context or no. You remember about the 120 days? In the thalassemic case, it's not the case. The exposure of the glucose molecule is not the same. We are talking about 90 days. We have 30 days less than the normal case. So we cannot apply the reference range, the 6.5%. It's not applicable in this case. The F is separated and excluded. I added actually the FY because it's the problem of all the separative techniques. We need a good resolution to be able to separate the F, because the presence of the F in all the general, almost all the separative technique, I'm talking especially with the HPLC, it's a problem. When we have an elevated hemoglobin F, you will have some problems with quantification because the overlapping is also problematic. And we will see, I will show you some examples later. The labile fraction of the hemoglobin A should not interfere. The carbamylated fraction also should be excluded from the calculation formula. This is a real screenshot, a real result of the A1C on Sepia instrument. You will report your result, you will see your result like this. It's just a normal, it's a real case, a normal screenshot. As you can see, the hemoglobin A1C is separated, the hemoglobin A is separated, all the other forms of the hemoglobins, the glycated forms of the hemoglobins are also excluded from the calculation and separation. And look at the hemoglobin A2, which is measured, separated, and extracted from the calculation. Excluded from the calculation means that we need only 2 fractions to calculate the A1C. And those 2 fractions needed to be clear without any interference. Those 2 fractions, to follow the IFCC rules, those 2 fractions are the A1C and the hemoglobin A. And to separate them with this quality, we need a high resolutive technology. Actually, the resolution is not an adjective, means a qualification. It's a parameter. A high resolutive technology, we should be able to separate all the fractions without any interference. Why? Because we need to quantify them again without any interference. This is an atypical case, an atypical profile with the presence of an hemoglobin S, in this case, detected as an S. The most important thing in this profile is to see how it is easy to exclude all the other forms from the formula of calculation. Again, the most important thing is to have a pure hemoglobin A and a pure hemoglobin A1C. In this case, even in the presence of a lot of other forms or hemoglobins, we are able to have the pure fractions. The hemoglobin S. What is the glycated fraction of the hemoglobin S? The glycated fraction of the hemoglobin S migrates here. It will be excluded from the calculation. The S1C will be excluded from the calculation without any impact on the hemoglobin A0, the native fraction, or the A1C. This is also another atypical case. The blind techniques or the separative techniques is not the Sebia words. They are the IFCC word. A blind technique means you will have a result. We don't know what happened exactly. You will have maybe an accurate result, but in which context? We don't have. We are talking about the immunoassays, we're talking about the enzymatic techniques. The separative techniques is not only the capillaries electrophoresis, all the techniques that able to separate the fractions and show all the fractions. HPLC, capillaries electrophoresis, some boronate affinity technologies. Again, why it is important to see in which context we are reporting the result. Because 6% in a normal context is not the same in a pathological context or in a presence of a variant or in a thalassemic context. This case is a double compound heterozygosy. You see the hemoglobin C, you see the hemoglobin S, but a lot of alarms. The most important thing here is not to report the result, because we don't have an A1C. If you take this sample and run it on a lot of techniques, a lot of methodology, mainly the immunology, immunoassays, etc., you will have a result. You will have the A1C 4.5%. But the most important thing here is not to report the result, is to detect that we don't have hemoglobin A, and we cannot report the A1C. After that, for the diagnosis, we have a lot of other parameters that we can rely on, like the fructosamine, like the cinetic of the glucose, like maybe now they are working on to standardize the glycated albumin. But the most important thing is to know that we don't have an A1C. This is the result validation for Sebia. It's a small detail, it's a small tool, but it's actually, for the high throughputs, very useful. We have a color code. For the normal samples, mean the normal values of the A1C, you will see the green color. The user of the capillaries knows actually what I am talking about. The orange color is for the elevated values of A1C. And the purple pattern are for the atypical profile. Means the thalassemic profiles or the presence of additional fractions that is very important to highlight them to interpret the result of the A1C in the right context. The HPLC result. It's a separative technique. Let's agree. The HPLC, it's a good technique because it's a validated technique by the FCC, and also it's a separative technique because we know, we see all the fractions. In this case, for example, the hemoglobin A is clear. We have the A1C, but we have other fractions, non-known fractions. So it will be more complicated than the capillaries electrophoresis to calculate, to use the formula of the IFCC. Why? Because we don't know this part, for example, this part, and this part are a part of what? A1C, the fraction before, is it hemoglobin F? And if this is the impact of the resolution. Again, the resolution is not an argument. The resolution is not a qualification. It's a parameter. Here we have 1.5 minute migration, which is logic. The most common HPLC or colon use are with this range means. And we have a tax. We can have a high resolutive technology like this one. The tax is the time. This kind of HPLC, for example, is 9 samples per hour. When we need to increase the number of samples, we must reduce the resolution. Look at the difference between the resolution. It's 20 samples per hour. To increase it to 40 samples per hour, the resolution will be less. This is the tax of the resolution. And the resolution is really important to quantify accurately the A1C. Sebia, as you know, is the same technology, the same capillaries. For 8 samples per hour of the small minicap, you will have this result. The same one for the Octa, the 43 samples per hour. The high throughput with the Tera 63, you will have the same result. The same migration and the same time for migration, which is 8 minutes. But the HPLC is the golden standard. Definitely no. Again, it's not Sebia. We have a master. This man is Dr. Kaswi-Kamp. Kaswi-Kamp is the former coordinator for the IFCC and one of the pilots of the project of the standardization of this parameter. So in one of, I had the chance to meet him and to ask him about the gold standard reference. Some commercialized method claim that they are standard reference. His answer was clear. Again, he's a part of the master, the IFCC. My answer is definitely no. When you use a test, it will be commercial test of one of the diagnostic manufacturer. It should be able to show that they are traceable to the IFCC reference, separation or quantification, and have the certificate of the IFCC. You can see all the interview on this link. It's available on Sebia website. The CEO of the IFCC, also Andrea Mosca, Professor Andrea Mosca, mentioning in a very famous publication clearly that the idea of that the HPLC is the so-called gold standard is outdated since long. It was true, but in the 18th, because it was the only and the unique separative technique. He is also talking and mentioning clearly that Sebia technology is the higher resolutive technology than the other techniques. So, just for your reference, because the work of the IFCC, it was not only to standardize, to redefine the techniques. The gold standard technique was also defined by the HPLC, by the IFCC. This is the gold standard technique. The gold standard technique is a combination between a lot of techniques, many techniques, and it cannot be commercial. You cannot find it in your laboratories. It's only available on the IFCC laboratory. One test, one sample, 9 hours. Enzymatic digestion, separation with the liquid chromatography, and the detection with the mass spectrophotometry, or the same, the enzymatic digestion with the separation using the liquid chromatography. Liquid chromatography is not the HPLC, yeah? It's very different. It's a colon, 1 meter colon. And the separation quantification using capillary electrophoresis. So this is the kind of the result that you will see. The formula is one. It's one formula, and it's defined again by the FCC. The A1C area, the A1C value should be the value of the A1C divided by the value of the A1C added to the hemoglobin A0. Again, the most important thing to use this formula is to have and to separate correctly, without any interference, those fractions. And the best way is to have a high resolutive technique. The methods existing in the market, according to their charge and the formula used for the HPLC, they are using the area of the A1C divided by the sum of the hemoglobin A's area. The boronate affinity is the lowest resolutive technology because it's separated two forms, the glycated forms and the native forms of hemoglobin, and they are using the total glycated forms divided by the hemoglobin. The immunoassay, the same thing, is the value of the A1C divided by the value of the hemoglobin to get the percentage. It's the primary thing and the only technology, again, and technique, you can verify it. Now, nothing is hidden. You can go to the sites, the websites of the NGSP, the IFCC, and you can verify it. The only technique following the IFCC formula of calculation is the capillary electrophoresis. The standardization as a technology, it's easy. We are using the IFCC, SEBIA, the capillary electrophoresis. Just for your reference, we are using the IFCC derivative calibrator. We are calibrating our instrument, and we are standardizing the A1C. So we are certified A1C. For the international guidelines and the recommendation on the diabetes diagnosis, the laboratories should use for the A1C a traceable technique to IFCC, means separative technique and using the calculation formula of the A1C. And should be certified also by the NGSP, because the NGSP is actually a part of the standardization. It's a part of the IFCC process. The values should be, for your lab, reported in IFCC unit millimole by mole, or also calibrated value for the NGSP. And for the analytical performance, the IFCC, the certificate of the IFCC, looks like this. We are not using only the CV. The CV was the only and the unique performance value, but now we are adding the bias for the IFCC. And the certificate now included 4 tiers, the gold, the silver, the bronze, the standard, and the out of range. The best one is the gold. The best performance is the gold, after the silver, and after the bronze. This is the result of SEBIA. The result of SEBIA is the unique and the only technology on the bronze, on the gold position, on the grade gold. Also, the EQAs are really important, and as you can see, one of the biggest EQA for the A1C is the Aero A1C. Just again for your reference, they are using more than 4,000 labs are using this A1C. The result of SEBIA is here. SEBIA is the best performer, also using the EQA, and the most famous one. Just for your reference, the silver, the gold, and the bronze, they can be used for the diagnosis and the follow-up. The second zone, all the parameters on the second zone can be used only for the monitoring, out of range, and you will be surprised. A lot of HPLCs and separative technique cannot be used actually for the monitoring or for the diagnosis. The take to finish, sorry for the delay to finish, the takeaway message, HPLC, the HbA1c is not the same as the total hemoglobin or the glycated hemoglobin. Not all methods are measuring the same thing. We are not measuring the same thing. Even the separative technique, we are measuring different things. Hemoglobin variant and thalassemia can affect the result in almost all the methods. It's important to see. It's important to see and to know the context to be able to judge. Faster doesn't not always means better. Remember the tax of the throughput. IFCC certification rank, you have the white, the bronze, the silver, the gold, can give you more data about the method or the instrument analytical performance, and also to choose your technique on your lab. It's all for me. Thank you so much.
Now we move to the end of the session where we have questions.
Yeah.
So first question is to Dr. Ahmad. Do you recommend to have screening protocol for all patients with high total protein, low albumin, low calcium, with low hemoglobin to detect myeloma at earlier stages?
Again, yeah, so screening for patients with high calcium level and anemia, you mean? Huh? Yeah, I think all patients, I believe, who has anemia and hypercalcemia should be screened for multiple myeloma. We know that not all patients will have hypercalcemia, so hypercalcemia might be masked here. So any patients with hypercalcemia, anemia, especially in the elderly, screening is recommended.
Okay, doctor, thank you very much. This was the only question for Dr. Ahmad. Now let's move to questions for Dr. Nair. Is urine Beans-Jones protein electrophoresis useful, or in light of other tests, not useful? Yes.
Current guidelines is to replace protein electrophoresis or Beans-Jones protein with serum-free light chains for myeloma patients, but for the amyloid patients, you still need a urine sample to immunofix.
I will just add to this question. Shall we not ask international guideline to change, because currently we have free light chain estimation quantitatively for urine sample. Now, if we can quantitate urine free light chain with very good methods, why to depend on semi-quantitative methods like urine immunofixation or urine Beans-Jones protein? So I am strongly in favor of stopping urine Beans-Jones protein. Now, what is your opinion for that?
Beans-Jones protein you can stop, but for amyloid, they've decided to keep the immunofixation.
Okay. Next question. Can you briefly describe advantages of moving to capillary electrophoresis from standard gel electrophoresis?
I think the workload, interpretation, better resolution, and you know, we do probably 100 electrophoresis every day. We couldn't have coped with the normal manual method and looking at this thing. So we did go, that is one advantage. And again, interpretation is easy with the capillary electrophoresis.
Mm-hmm. Okay. Next question. Since the IgA monoclonal proteins migrate early, and might overlap with other normal bands, do you recommend running immunofixation for all cases that require electrophoresis?
So if you've done an electrophoresis and you see a distortion, then immunofixation.
Okay. Dr. Girish, do you have a comment?
I think what the question means particularly, that sometimes even we may not see the distortion and the band is hidden behind beta, you know, right? So such cases may be missed unless we do IgA immunoglobulin estimation, or that's a different thing. But we certainly miss such cases, you know. So that's why the question is, shall we do?
That is the question. Okay. I don't think we can do electrophoresis on all samples, because you will receive around 3,000 samples a day. And if you electrophorese every sample, that's not cost effective. There may be multiple myeloma related clinical symptoms, and if you don't see, if you didn't see a monoclonal protein, probably those are the patients you can do immunofixation, not all patients.
Now here we have seen the advantages of capillary electrophoresis.
I understand, but capillary electrophoresis also, I don't think you can do 3,000 samples. It still needs someone to look at the look at the interpretation?
What is happening that in serum protein electrophoresis, we are seeing many faint bands or unclear bands or maybe like oligoclonal pattern, maybe. So such faint bands, what to do?
We do immunofixation on those. Because, you know, it picks up 1 gram per liter. So if you see a band, you need to do immunofixation.
Yeah, but our experience shows that recently, in last few years, the incidence of such faint bands or oligoclonal pattern has increased. Now, maybe due to the effect of treatment or some, maybe Dr. Ahmad can clarify this, either effect of treatment or some other drugs, or our technology has improved a little bit.
If you do an immunofixation and you can't see in the immunofixation, at least you can be safe that it's not a monoclonal band.
Okay. Can Dr. Ahmad say about this? Some drug treatment which you have introduced in last few years.
Yeah, the monoclonal antibody, the daratumumab, is an IgG kappa, so it is sometimes interferes with the protein electrophoresis, making a false positive unbound. So the first question to ask whether the patient is on monoclonal antibody or not. And number 2, I think, why did you request for the serum protein electrophoresis to start with? If there is a suspicion of multiple myeloma or plasma cell disorder, I think a faint band should be repeated and complemented with immunofixation and probably doing also a free light chain assay.
Okay, thank you. Thank you. One more question for Dr. Devaki. You mentioned in SP report pattern that nephrotic syndrome and liver cirrhosis reports may not be important, so shall we stop reporting that?
These are the patterns you might see, and you need to know what the picture is for nephrotic syndrome and liver cirrhosis. Because the gamma globulins will be high, and it's a polyclonal increase, especially in the liver patients.
Okay, so if we see in the report, we should report.
Right? You can report. We report. We report likely to be liver related, but if the clinical question is there a paraprotein, you can say there is no paraprotein visualized, because electrophoresis is not going to add any clinical significance to a liver patient except to say that it's a polyclonal increase.
Okay, for one question for Mr. Aymen. Whether it's regular HbA1c measurement with HPLC or capillary electrophoresis, HB variants cannot express the glycemic status of the patient. So what's the difference?
Actually, there is no difference between, it's not about the difference, it's about the context. We need, because we have, when we standardized this technique, we established a cutoff, the 6%, to define the pre-diabetics, the diabetics, and to adjust also the treatment. It's very important to know the existence or the context in general, mainly in presence of the variant, to understand and to interpret correctly the context. Again, in presence of a beta variant in general, the patient will be his own reference. The cutoff, the established cutoff with 6% will not be used for those patients. The 6% is used only for the patient with a normal profiles of hemoglobins with the A and with the normal A2. In case of thalassemia or in case of the variants, the patient, the value is not the same. It should be his own reference.
Okay, thank you very much, Mr. Aymen.
Thank
So
you.
now we conclude our session, and we'd like to invite Dr. Ibtisam now to give certificates to our speakers.